Okay. Hello, everyone. We'll make a start. Welcome, everyone, for another interesting day on hot topics for the medical interviews. A bit about me. My name is Dr. Anand, and I am a consultant psychiatrist. I work in Bradford University, Yorkshire, and I've been involved in teaching, especially for medical students, over the last 5 to 6 years. We have been doing it more informally in the early years, but over the last few years, we have formalized things so that it benefits and we can sustain in the long run. I like to welcome you all for this 90 minutes of interesting talk on various hot topics which will be useful for the medical students. Our aim of the Educate the World is to offer cost effective, high quality education for everyone, not only medical, but in all spheres. And we have been doing it successfully with the help of like minded senior doctors and aspiring medics, including the medical students. I really thank all the speakers today who are all much senior and have achieved the top in their respective fields for spending their time, especially on a Sunday evening, to come and talk to you. Overall, the purpose of our medical interview session is, as we said before, it's practice, practice, practice. So the more you practice, there are no surprises when you attend your real interviews. So we help you to practice in terms of arranging group sessions, one-to-one sessions, and peer-to-peer sessions, which we have started recently. Today's purpose is to talk about topics which the medical students might come across when asked in the interview or in group discussions. What would be nice would to hear from the specialists in their respective fields to talk about topics which the medical students can use when asked in their questions in the real exam. So with that, we will make a start. And let me introduce my first speaker, who is Professor Rohit Shankar. Professor Rohit Shankar is a professor of neuropsychiatry in the University of Plymouth Medical School. He has the honor of receiving a medal from our late Queen. So he's a member of British Empire for his contribution towards research and especially in the field of epilepsy. So he's a top researcher in this country, and he has generated so much of research activities and papers. And so, who else to listen for what are the aspects of research for aspiring medical students? Over to you, Rohit, and thanks for joining today.
Thanks, Azil. Really appreciate it. And I hope to keep my talk succinct. I'll just share my screen if that's okay. I guess things are visible. Yeah. So basically, I think Azil has asked me to talk about ethics and research. Both in itself, I can talk for 3 days on ethics and 3 years on research. So I don't think that's going to help any of you here. And I expect, and anyway, the nice thing about it is most of my talks are used quite frequently. They're pretty much downloaded, most likely to treat insomnia, I think. So 10 minutes is the right duration to get through a few things here. So ethics and research. So your lesson starts right here. So the first thing here is I'm a professional beggar. Why do I say that? The reason for that is my whole livelihood now based on earning grants, publishing papers, and basically telling people how well I can change their lives. That's the bottom line of it. So it's a index of vanity and narcissism. But what in this context, as I said, as a professional beggar, literally I get grants from different sources. And that can be, as you will see there, from industry, pharma industry, tech industry, etc., from the government grant system. And all that goes to develop various products. Then some of the products I would have also skin in the game, so to speak. So I would, of course, want their benefit. I want to prove that they are good. I want to sort of highlight that they can make a difference. So what it does show is that anyone and everyone, including yourselves and myself, we all have a bias. So, irrespective of what we do and how we do, we are all biased. The important thing here we have to always realize, and this is central to the discussion that I'll be presenting to you, is that the more we are aware of our biases, the more we can actually take a more neutral judgment. So we have to accept, we'll always be biased, but we have to accept our biases in the manner in which we are obvious to know of it, to actually be as ethical as possible. So that sort of sets the scene, and that's the foundation of the talk here. So, what I'm going to very quickly rattle through is basically the background of where ethics sit and how did ethics in research evolve and where has the evolution come to. I'm going to talk you through where the practical applications sit at present and the challenges which lie there. And then, of course, move on to very quickly the summary of it. So, basically, the background, so you already know what's already out there in one way. So the first thing which is there is ethics is not a new thing. It's as old or as young as mankind, humankind, person kind. So you can talk about ethics from the 10 commandments. So the 10 commandments set rules, their morals, or you can even talk in the medical field about the Hippocratic Oath. So that again is very much ethics. The very word ethics comes from the word ethos, which means custom, which is to do things as per norm. That's the way it is. And it is about the conduct. So, in general, we as humankind basically have always striven to have particular rules of conduct. Now, one of the interesting challenges is that the rules of conduct, such as, say, right or wrong, we grow up with them in childhood. You're taught by your parents, family that you shouldn't lie, you shouldn't steal, you shouldn't hurt someone. So there are certain right and wrongs there. However, moral development is very different to right or wrong. Moral development is where we bring in an active judgment on issues. That tends to grow all our lifetime. So the moral development which I might have had as a child is not what the same I have now, because that's where you require more evidence, you require more understanding. If you're, it also depends on whether you use Daily Mail as your evidence base or whether you use a sort of a nature as your evidence base. None of them are actually wrong, and none of them are not evidence based, but they would help you with your moral development. The reason for this is that at a balance of it, we need to consider in ethics about how do we justify harm. So harm tends to happen and it is proportionate. So even whether it's childbirth, whether you give an injection, whether you actually take blood for research, whether you do a survey, you're causing technically in some way some harm. So that aspect of harm has to be justified with the relativeness of the good that can come out. And this then hinges on communication, cognition, and choice, which has to which are presumed in most times, but have to be sort of tailored to the person. And that's quite challenging in that way. So this is all the landscape and the background that's all there. I mean, I'm talking of something like 4,000 years of work here in 4 minutes. So it's not going to be easy and it'll come across pretty waffly, I expect. But coming to now how we have evolved things, so I think the watershed moment has always been wars. People tend to learn a lot out of wars, and lot of what, and contrary to popular belief, a lot of good actually comes out of wars. And what you did have is after World War II, where there was a butchering of, say, Jews for medical reasons, etc., there was the evolution of how we should be actually looking at practices, especially clinical practices. And the Declaration of Geneva in 1948 was the first declaration which identified the modern Hippocratic Oath. Then the next big declaration was the Declaration of Helsinki, which formulated what's known as currently the Good Clinical Practice Guidelines. So that's evolved from 1978 Declaration of Helsinki, but it is originally labeled to the 1964 model, which raised the good practice around the medical research on human subjects. Then the Declaration of Tokyo in 1947 highlighted how physicians cannot and should not be complicit in torture, and how it's our duty to prevent torture. Now, as things expand and we go into biobanks and big database, there was the in Washington there was a big council in 2002, and then there was the Declaration of Taipei in 2016, which has identified the best practices around health databases, big data, and biobanks. And all that set premise to what research ethics is. So research ethics, I'm not going to go through this whole list here. I'm sure you can pause the video when you see it and look through it. But the key aspects of research in here, it comes down to two words. So what? So what are you going to be doing in research that's going to justify any harm? So what? Any inconvenience? So the so what question has to be first answered. And in a research this thing, when you'll go for NHS ethics or any or even for any program grant or any grant where you have to build an argument about what is it new that you're discovering, how is that what you're going to discover new going to have an impact on a population, the study population? How are you going to ethically try to work it out and justify that and minimize harm? And how are you going to bring in uh, a solution, which if you get a solution into practice? And one of the best ways to do that is to include experts by experience, people who have lived with that condition or who have had families who have died of those conditions are some of the best advocates and trainers for this. So you need to keep that in mind that research ethics, the formula for getting research ethics right, is very much start with a very clear question of where it can be actually suited to patient benefit, have the right sort of patient groups linked in with it to help support that research, and then mobilize it forward in a manner in which it is ethical, minimally intrusive, and positive outcomes there. So that's ethical research, but then also publication. Always look at your own biases. Why are you doing what you're doing? What has drawn you to that research? When you're publishing, what exactly are you telling? Have you actually told everything that's there? Have you actually sort of glossed over or minimized any negative findings? These are things which are very important. And our own biases, because we think we need to tell someone and we think it's right. Even today, I am going to be biased in what I'm telling you because there is going to be aspects of research which I think might be which should be relevant, which might not be coming across here. But moving on very quickly, so we this is always challenging. Ethics in research is always challenged with new developments, and nothing more than now. So if you take the conventional challenges which we have, many of you here would be familiar with the Roe and Wade case with regard to abortion and abortion rights. Now, this, especially for a physician, and in particular for a researcher, can be quite challenging because A, you bring in your own biases. B, you're entering into a very controversial subject. C, you need to keep the focus on the research question and not the noise outside. So these are conventional challenges, which are very good cases in illustrating how and what research gets done. One of the ways to actually overcome that is to actually claim your bias and say that you're very pro abortion or very pro anti abortion, in which case you're basically your findings will be looked upon through a prism, but at least it protects you from being accused of being biased incorrectly. So that's there. Same thing now is happening with complex issues like assisted dying. So where people want to, so you have the country, in the country, there are surveys which have been shown that around 80% of of England supports assisted dying. Doctors, on the other hand, really are not really keen on that. And I think there is a divide here. And again, research is very much needed to understand this divide. But more importantly, it's the nature, type, and who does the research, which is going to be challenging. So these are conventional issues which are there. But let's also step forward to futuristic challenges. So futuristic challenges are very much AI, artificial intelligence. And this is again a spectrum here from the fact that you can use AI, and I have used ChatGPT to trial out things, and it makes up its own stuff amazing, the S bar and stuff. I mean, it quotes me in a wrong way. But the thing is, some people use it to even now actually develop their papers or PhD reports or their master's thesis. Now, how ethical is that? We don't know. How ethical is it to actually present the research through those sort of processes? We don't know. Generative AI is going to be a big challenge, especially with regard to ethical matters. Now, what you do have is that it's not just there. It's about how do we use AI with regard to clinical practices and how does the research sit with that. So as you can see, we are opening up a big Pandora's box here, which is needed. Of course, it's needed, but it needs to be done in a structured and systemic way. And you really have to move to understand where this fits in. In a nutshell, what we do need to do is move the unknown unknown to the known unknown before it becomes the known knowns. So this is very much about trying to get your head around all the blind spots here. So this is my last slide, going through it quickly. So what you do have is four principles of ethics, which apply in general to clinical science and in particular to research. You got autonomy, you got non-maleficence, you got beneficence, and you got justice. Now, what do they mean? Beautiful words, and will come in very well if you're playing a Scrabble game. You can get lots of points on that. What autonomy means from an ethical perspective is that the patient should be allowed to exercise his or her capacity for self-determination. So they need to make up their own minds. But it is our job to give them every bit of information as possible to make up their own minds. It's not good enough to go and say, this is a good thing. Do you want to join it? You're going to get 10 pounds for this. Would you like to give your blood for it? It doesn't make sense. You have to work out all the negatives, identify the positives, and present it to them so that they can exercise their own self-determination on it. What is non-malfeasance? It's basically our obligation as researchers and clinicians, especially clinical researchers, not to harm the patient. So we have to make sure that we do not harm the patient, but this is taken in perspective about the broader good that you might want to do to society or to the individual themselves. So there is that issue there, and that's a big debate which is there. Then you have beneficence, which is the obligation to act for the benefit of the patient. So as you can see, 2 and 3 actually might be counterintuitive at times. And at times, these two do not reflect on the larger good for society. Like when COVID happened, testing vaccines was important. In a particular chunk of people, it might have caused harm, but for the greater good. And you have to sort of get your head around that and to work through that, which is basically where quite a lot of the justice issue comes along about fair, equitable, and appropriate treatment of persons. So that is the balance of it. So these are the four pillars on which we base our ethics foundation, and we go from there. So that's autonomy, non-malfeasance, beneficence, and justice. I'll end there. I think 10 minutes goes really fast, and I don't want to step on somebody else's toes. Thank you very much for the opportunity.
Thank you very much, Shankar. There is more like a whistle stop tour of research, and I know how difficult is it for you to summarize everything in such a short time. Um, we are all really grateful and thankful to hear from such a senior. It's like hearing from the horse's mouth. The things about research and what you talked about, the four principles of ethics, autonomy, and things which I'm sure students can quote it in their interviews. And there are also other things you touched upon, use of artificial intelligence, and other things which might come in the interviews, like assisted dying and animal research. So thank you very much, Professor Rohit Shankar, and I really appreciate you spending your time and coming over and voluntarily for us. Thank you. Okay, so next we move on to our next speaker, Dr. Raghuraman. Dr. Raghuraman, many of you would have known. He has been with us over the last few years and has been part of our journey. He's such a helpful and kind doctor who has helped people personally as well as professionally in many ways. He's a consultant in anesthesia and critical care medicine at University Hospitals, Birmingham. He was previously a medical director at Queen's Elizabeth Hospital at King's Lynn. He has more than 22 years of experience as a consultant and 15 years experience in senior level management within the NHS. We all know NHS is a hot topic for all the students. So he's going to talk about the general NHS structure and management. Over to you, Raghu.
Thank you. Is Priya going to be loading up the slides?
Yes, Priya, do you want to share the slides?
Yes.
Thank you.
Thank you.
So while she's doing this, good evening and thank you for the opportunity firstly. As Rohit mentioned, I think the topics chosen today, I think 10 minutes probably don't do justice for them. But I think we have to pitch it to the aspirants of people who are entering into medical schools, and also to the level of understanding that we need to have, and possibly understand and respond to how these lines of questioning and what would be an appropriate response to them. So that's probably where I am going to probably pitch my talk today. And my topic is even probably more complex in the sense that what are the challenges faced by NHS? In my 15 years, I think the challenges haven't receded, haven't gotten better. In fact, it's gotten worse. So next slide, please. So rather than talking through the entire group of what needs to be done, I'll just briefly go through the current challenges facing NHS, especially in the aftermath of the COVID pandemic. What do you think are the solutions that we can offer and what needs to be done? But easier said than done. Again, change in NHS is extremely difficult at this point in time. And what does it mean to you as an aspirant to medical school? How can you contribute to the solutions? Perhaps that may be the line of questions that you may be faced with when you are being asked about the challenges in this, and what the information I'm going to give is going to provide that answer or perhaps some input into that. Next slide, please. So this is going to be, again, a whistle-stop tour, but I would urge the audience to these two key articles that are recently published. One is about the challenges itself. It's showing that was published in November 23, this very recently, and the other one is the King's Fund document that tells you how the NHS in England currently work and how is it changing. And the changes have been accelerated over the last 20 years, and there's been multiple of it, but you need to know how the money flows first, but equally how the changes are made from the top to the front line. Next slide, please. So given the enormity of the challenge, if you were to ask me to say, summarize the key challenge that is the biggest challenge for NHS at the moment, and that is the root cause of all the problem, I would put it down to the mismatch between demand and capacity. The demand in the system in NHS is growing, and the capacity, which I will share my experience and some of the information in the next few slides, the capacity is shrinking despite the fact that we are trying to increase our workforce. So if we were to ask a simple question, it's a mismatch between demand and capacity. That leads to queue, that leads to stagnation, that leads to overcrowding in every part of our healthcare, and that is what we find at this point in time. Next slide, please. So why has the demand increased? And this is a very key question for us. The answer to that is probably multitude. People in our country are living long, but they are living with a multitude of long-term conditions, which the access to healthcare is very important to keep them stable, but keep them well outside of hospitals. Currently, with that condition, with the older generation of people, I think we are struggling with the burden that these conditions pose to us and keeping them in the normal state of health. The second thing is the key risk factors that I think we can change, we can influence, we can modify are the areas around what we can change around smoking, dietary style, and alcohol use. I think needless to say, although the incidence and prevalence of smoking has come down, alternate means of nicotine inhalation and replacement are still in vogue, and they are on the rise. The other thing is about we've got a huge chunk of obesity in our country. Equally, there's an increased prevalence of childhood obesity, which is now spilling over. About two-thirds of our population are obese or morbidly obese, and they pose a lot of healthcare burden to our society. And alcohol abuse, needless to say, has increased, especially aftermath of COVID. And the other factor is that COVID caused a huge amount of stagnation in our care. So there's a lot of hidden need of care that needs to be provided, and that is slowly started to surface as the pandemic started to recede, and we are still haven't gotten over it. So there are a few things that the population and the people and their lifestyle factors are contributing. Next slide, please. We haven't funded our NHS enough, and that's been a decade of underfunding that has been in place. So our infrastructure to deliver the growing demand has not kept in pace with what is needed at this point in time. So if you look at how we have spent, the graph clearly shows that we are about 60 billion short in the last decade to in our healthcare spend with the growing demands. And needless to say, without this funding place in place, I think the delivery of care would be extremely difficult. Next slide, please. So what is the consequences of this? Now, if you look at the increased demand, we have the lowest bed per thousand population in Europe. We have the lowest number of critical care beds in the thousand population. All of this signify that our patients, although being old and increased levels of comorbidity, are not able to access these care because of the capacity constraint within the NHS. So that leads to stagnation within the hospital. Hospitals are overcrowded. We have patients who have their care delivered in ambulances, and that's getting worse in winter. But equally, there is an outflow block from the hospital into the community. So the whole thing, the flows comes to a standstill if our capacity to handle these patients are poor, and we stay very low in this order of bed capacity in the country. Next slide, please. Our workforce vacancy has been very constant and has almost 10% of our total workforce requirement. To top it all up, I think the medical workforce, we have a growing, aging medical workforce. There are two things that are happening in the medical workforce. One is there is a migration of medical workforce to other healthcare systems. You probably would have seen them in the press, but equally, due to the economic factors, the salaries and the lack of pay rise, I think a lot of doctors are either resigning, retiring, or moving away from the healthcare system. And that is causing, and the loss of experienced clinicians is causing a lot of constraint. Even if you replace for a head-to-head count, I think the experience lost is probably still significant in the way the healthcare currently functions. Next slide, please. So what is the end result of this? What is the consequences of this? NHS is typically measured by three key parameters. One is your A&E performance, your ability to treat patients, treat, refer, or admit, or discharge patients within 4 hours when they present to A&E. That's one of the standard markers. If you look at this graph and post-COVID, and still now, I think 25% of the patients are unable to get out of the A&E within 4 hours. And the ones that get out of 4 hours are the non-admitted patients. The admitted pathway is far, far worse. And I alluded to the bed capacity in the previous slides, and that is one of the major constraints here. So your flow, emergency flow, eats up into your other activities of the hospital. Your beds are congested. The other measure that we use currently is for cancer treatment, which is again a very important thing for any patients. And you'll be hearing from Dr. Ramkumar on the recent advances in cancer. But the problem, fundamental problem, is patients getting access to cancer treatments in NHS. That is not happening in the way. And if you see the graph on the left lower corner, the 2-week waits, patients who are referred to clinics should be going through a system where they can be triggered and triaged into a pathway, is far, far lower than what we expected to. 92% should go through. We are probably somewhere around the 70s. And the patients who have been diagnosed to have cancer should have their treatment initiated within 62 days, 2 months time, which is a reasonable time. We are not able to get that through either. So that's a significant decline in the cancer treatment for our patients. So when you look at the elective care for this group of patients waiting for a 18-week referral treatment pathways, which when a patient is referred by the GP to the hospital for specialist care, we are expected to treat them, at least initiate treatment in 18 weeks, and look at the rate of rise. About 7.5 million patients are currently waiting in the 18-week pathways, and half of them are still waiting beyond 18 weeks. Our NHS is only treating 56% of our patients within 18 weeks. We should be treating 92%. So you can see the backlog that is being built as a result of the congestion, as a result of the demand that is placed on the demand and the constraint in the capacity. Next slide, please. So I think, what does this mean for you all who are aspiring to become doctors for the future? I think you need to be looking at the solutions first. One would say, okay, throw money at it. Oh, of course we can throw money at it. We can probably print more money than can get more money out of the gold that we reserves that we have. I don't think we have enough money in the system to do that. But having said that, increasing the funding alone will not change the situation here, purely because it takes time to build the infrastructure, which we have been underdeveloped for the past decade. But equally, we should be looking at how we provide care out of the hospitals better, because we need to keep the patients and the population well in the community. The biggest cost of healthcare sits with the secondary and tertiary centers in the country. 60% to 70% of the budget is consumed by the acute providers. So your prevention and keeping them well is taking a hit as a result of it. But equally, we should be looking at mechanisms to provide those care well within the community, and we should be looking to provide this in an innovative way. I suggest that we think of how we deliver them through 3 I's. One is innovative way of doing it. We need to integrate. We are working in silos: primary care, secondary care, and community care. We have mental health care. All of them work within their own compartmentalized. They don't talk to each other in a way they should be, and we are not coordinated, and we are not patient-centered. I think that integration is integral to delivering a better care in the future. One of the things I have put implementation as the 3rd I. I think implementation, although it's easy to say, what's wrong with implementation? In the day where change is so difficult in NHS is like a super tanker. Changing the direction of travel is extremely difficult. In my past year, for 15 years, this is one area where we struggled to get through. Even a small level of change. Imagine the amount of changes we are talking about, integrating big care systems in the healthcare. So implementation is the next one. So what is this that is going to be relevant to you? One is being aware of this. What are the problems NHS is facing is very important for you to look at problem solving. So you, as aspirants of being a future medic, being aware helps you to focus on where you need to deliver your care, what kind of care you can provide, and how you can then align with what is needed for the NHS. I think one is the next thing I would say is, by becoming a medic, you can align with the NHS principles. You can align better by understanding what the problems are and be part of the solutions here. The key qualities of what NHS is looking for in doctors at the moment is about how you listen, how you communicate, how you work well within the team, how you're accountable for your actions, how do you provide compassionate care, and how do you have integrity and aligned values across your healthcare, and how humility is one of the key attributes that is expected of you. So when you get asked these questions, I think these are the areas where you should be focusing to say, if I do get into this, these are the values, the core attributes I will be aspiring for as a doctor in NHS. Next, please. So I'm going to summarize by a few bullet points. One is about the current challenges. It's enormous. And it's got to have a combined way of delivering this, not as a compartmentalized way, which is where we are at the moment. Solutions does not just involve increase in spending, but how we deliver care in futures. I'm going to allude to the three I's of the how we implement, how we innovate, how we integrate our care, providing the best patient-centered care. Being aware of the problems helps us focus on the solutions, and becoming a doctor who aligns with this core purpose is the doctor we want for the future. Thank you.
Thank you, Raghu. The talk was very insightful and offering very practical advice to all the young A-level students or even other school students who are looking for a career in medicine. You have always been very inspiring to others, and I can understand, why you have been a very successful medical director with your views on the NHS and also with your communication skills. Hope you can stay. If you can stay towards the end to answer any questions, you are welcome. Thank you, Raghu. We are next move on to our next speaker, who is Dr. Shakti Karunanidhi. Is an experienced public health physician working as the Director of Public Health for Lancashire since 2013. Is a chief officer responsible for protecting and improving population health, addressing health inequalities. Is an advisor to the NHS, local government, and wider public, private, and voluntary community, faith, and social enterprise sectors. He led the public response during the COVID-19 pandemic in Lancashire. He's very much into public health, and is always interested in people. Sometimes people mistake him as a spiritual leader, but I have to say he's interested in yoga, meditation, and in fact, he's writing a book on how yoga and meditation can help in scientifically help in healthcare. So over to you, Shakti.
Thank you, Dr. Anand. Nice to be here. So I've got the topic of public health initiatives in the NHS, particularly aimed at preparing for interviews. So I'm going to be keeping it really focused on that. And Dr. Raghuram already indicated why the capacity and demand is very challenging in the NHS, and the importance of diet, alcohol, and tobacco, for example. So just one thing, if you want to have it in your response in your interviews, if there is one preventable, single most important, entirely preventable cause of ill health, disease, and disability, it is smoking. It causes about 64,000 deaths in our country. And actually, no other consumer product kills up to 2/3 of its users if they use it as directed. So just bear that in mind if you want to really focus on prevention, and if somebody is asking you what can we actually do, this is the single most important preventable cause of ill health, demand. About 1 in 4 of all UK cancer deaths is caused by smoking. Okay, so that is just a brief introduction. The public health, why this is important. We already listened to Dr. Raghuram about demand on NHS. This is a slightly broader view, because one of the ways to measure how healthy a society is to measure the life expectancy, which is the average number of years a child born today is expected to live. And what is happening in our country is between the poorest and between the most wealthiest parts of the UK, there is 10 years of gap. How long a male child born today is expected to live, and 8 years, over 8 years for girls. So that is one of the very striking features even in the UK. And narrowing this gap, we need to focus on prevention as well as addressing the broader determinants of health, which I'll briefly describe to you. So that is why improving public's health is important, to help people live longer and healthier, as well as reduce the demands and challenges on the NHS and indeed the public spending. So public health is not a very popular or very well known specialty in medicine. It is a higher specialty in medicine. It's about helping people to stay healthy, protecting them from threats to the health, as well as we've just seen, reducing the inequalities between different sections. In practice, this includes a range of things, from addressing education, housing, reducing poverty, improving employment, air quality, climate change. So that is one dimension of public health practice. The other dimension is improving food and diet, addressing addiction to drugs, alcohol, smoking, as well as helping people to be more active, physically active. That is a second dimension. And then there is more clinical dimension of public health, which is about early identification and treatment of risk factors, high blood pressure, cholesterol, irregular heartbeat, early identification of cancer. So that is broadly called secondary prevention. So this might be a phrase that you may want to note it down. Secondary prevention is about early identification and the management of the risk factors. And this slide, we are going to this presentation, just focus on what the NHS initiatives are, because to improve public health, we have to work across all sections of the society, from international collaboration to government level action to wider building blocks, as we saw, like housing and education, as well as the NHS. So this is focused on purely what is mainly in the NHS for the purposes of interview preparation. In the NHS, there are two big programs. One is, they're all part of an NHS long-term plan. So the NHS long-term plan was launched about 10 years ago, and it is still there, and it aims to address the demand and capacity, as well as the money that is spent, and also address the situation about workforce. But within that, there is a program called NHS Prevention Program. We won't have time to look at each one of the elements of the prevention program in detail, but you will have the references at the end. You can read about it at your own time. But you can see there the types of things that are there in the NHS under the prevention program. It ranges from helping people to manage overweight and obesity, including one of the I's that we've learned about, innovation and using digital technology to motivate people, addressing the alcohol dependency, smoking, HIV prevention, early detection of HIV and treatment, as well as some of the oldest infectious diseases like tuberculosis. This is becoming an issue, especially with all the migration related issues, as well as antibiotic resistance. So that is why TB program is becoming important. And secondary prevention, as I told you already, it's about early identification and management of risk factors, including diabetes, cancer, cardiovascular disease. Those are the main diseases that actually kill people prematurely. Cardiovascular diseases, cancer, respiratory diseases, and GI, gastrointestinal. Those four together causes much of the illness of the overall population. Although that is deaths, suffering also happens through mental health, which is often overlooked. So focus that also in your responses when you're addressing what are the key causes of ill health. It is cardiovascular disease, respiratory disease, cancer, gastrointestinal, as well as mental ill health. Now, this is the more latest version of addressing health care inequalities in England, particularly. This program is called core 20 plus 5. So this might also perhaps fetch you extra marks if you show familiarity about healthcare inequalities and what is your understanding. This is a program that is aimed to address the gap, what we saw right at the beginning, the 10 years of life expectancy gap between more deprived and least deprived areas, and 8 years for women. This is a program called Core 20 plus 5 that is aimed to address that inequalities. I will just explain to you the Core 20 plus 5, what it means. The Core 20 is areas, small areas, which are the 20 most deprived areas in the country, or the 20th, the lowest, 5th, 20th percentile, 20% which are most deprived. And by deprivation, we mean, poor, poverty, low levels of education, poor housing, poor employment. Those individuals, people living in those circumstances, die early, have got a longer duration of illnesses and disability, and they miss out in their employment, and generally their lives become miserable with a lot of long-term conditions. So the focus is on how do we improve the access on the 20% of the most deprived areas. That's the core 20. The plus is all the other inclusion groups. And again, this might be a topic that you may want to research, inclusion groups. So these are groups that are more vulnerable groups, like people with disabilities, the ethnic minority individuals, people with learning difficulties, traveler community, Gypsy and Roma traveler communities. So that is the population that nationally is being prioritized, along with the 20% of the most deprived areas. And then the 5 stands for the 5 areas which you see there, clinical areas. So maternity, how can we ensure continuity of care, particularly for ethnic minority communities living in most deprived areas? The second one is mental illness. I talked to you about mental illness. How can we check for people who have got severe mental illness? They also have physical illnesses as well, and they often get overlooked. And this is about making sure the physical health checks happen for people with severe mental illness. That's the second clinical area for addressing health inequality. The third one is chronic respiratory disease, often called chronic obstructive pulmonary disease. For that, those individuals, they're more prone for respiratory infections, and they can be prevented through vaccination programs, and also through planned anticipatory care, so the exacerbations or flare-ups don't happen, especially in this weather like winter. So identifying these people, engaging with them, communicating with them, and encouraging them to take up vaccination programs, and educating them to look out for exacerbations so that they can take the medicines on time. The fourth clinical area is early cancer diagnosis. The more earlier we pick up the cancer, I know there is a topic next on cancer, the more earlier we can identify, the more amenable it is to manage well and to reduce the chances of spreading, as well as the deaths. We saw cancer is one of the causes of premature deaths. So the program here is about early identification of cancer. There are a number of cancers: breast cancer, lung cancer, cervical cancer, bowel cancer. Those have got cancer screening programs, and people who have got symptoms like abnormal bleeding, for example, they are fast-tracked to early diagnosis. And then the last one is hypertension, blood pressure, high blood pressure. We know that only about 50 to 60% of people who have got high blood pressure are actually registered as people having high blood pressure. And then the proportion, similarly, it happens, it reduces. Those out of those who are actually known to have high blood pressure, the chances of successfully controlling the blood pressure is lower than, it is again in the region of 60 to 70% average. So that causes heart attack, stroke, as well as kidney disease, and number of other long-term conditions if it's not managed well, including in old age, dementia, and so on. So these are the 5 conditions that are the core 20 included in the core 20 plus 5. And I have already mentioned the smoking, so that cuts across all the 5 clinical conditions. And more recently, there is also a similar core 20 plus 5 specifically focused on children. So asthma, diabetes, and epilepsy are the three conditions that are focused on children, core 20+5. So these are some of the latest programs happening in the NHS that you will definitely show that you are familiar if you are referring to these in your interview responses. I've given some key, if you're interested in further interested in career in public health and to learn more about it, there is some references there, and I will share the slides as well through Dr. Anand. Thank you again. I'm happy to stay and answer questions at the end.
Okay, thank you very much, Shakti. We all, I'm sure, like me, you will feel privileged to get the information from all the top leaders in healthcare, and I feel really grateful and blessed to get all the information, and especially all this information is tailored to the young students, who will be able to use it for the study, for the interviews. Thank you very much. We now move on to our next speaker, Dr. Ram Kumar. He's a consultant clinical oncologist at University Hospital Southampton, and an honorary consultant clinical oncologist at the University College London. He is interested in new technical developments in non-surgical management of cancer. He's one of the top cancer specialists in the country, and he did his initial cancer training in India in 1997. But following that, he did all his training in the UK and has been worked initially in Southampton since 2009. He has numerous hats on, including postgraduate training director, college tutor, medical director, and he has been a PI, which is a principal investigator for several research studies. So over to you, Ram Kumar, to talk to us briefly about the latest advances in cancer treatment. Can you unmute yourself and speak, Ram?
Sorry, Elliot, can you see my screen?
Yes, perfect.
Okay, thank you. So I'm being given the task of talking briefly on advances in cancer treatment. Unfortunately, as other of my colleagues mentioned, it's a short time, but I'll try to do some justice. Oops. So I'll just give an overview. The treatment modalities include surgery, radiotherapy, chemoradiotherapy, chemotherapy, immunotherapy, and vaccines. And the treatment depends on the patient factors and tumor factors. Tumor factors include the type of tumor, the site, the stage, the findings, as well as patient factors, including performance status, patient wishes. So just briefly on surgery, the conventional surgery is what has been for many, many years, or many decades. And the laparoscopic surgery has come in probably a few decades ago, but the recent development in cancer treatment is robotic surgery. You can see here on the bottom of the screen where a surgeon sits in front of a Da Vinci robot and then operates and try to do the operation. This is more coming into work mostly for prostate cancer and to some extent lung cancers. This seems to be more precise in trying to have a more detail of the operative field for the surgeon. So coming to radiotherapy, there are two types of radiotherapy. One is brachytherapy, which means internal radiotherapy, and the other one is external beam radiotherapy, using radiotherapy externally. And there are different types of external beam radiotherapy, from superficial X-rays, photons, electrons, intraoperative radiotherapy, stereotactic radiosurgery, SABR, charged particles, and flash radiotherapy. So brachytherapy is using internal radiotherapy, where if you can see in the bottom left, where prostate cancer is being treated by inserting needles into the prostate cancer, and you deliver radioactive isotope close to the tumor. It has been there for many, many decades, but the recent advantage is that we're using more imaging, such as MR scan, to allow for adaptive brachytherapy so that we can increase the dose. Previously, we used to just calculate them and then just insert the seeds, but now we're getting more and more precise imaging. You can see on the right-hand side, you have a breast cancer chest wall where you're putting lots of implants and you're treating them with brachytherapy. Now, coming to external beam radiotherapy, this is what a linear oscillator looks like. It's the machine that delivers X-rays, which could be what called photons or electrons. And this is the couch where the patient lies down and the beams comes through this machine. Generally, we talk about 65 to 70 grays, which is the dose, which is given in 30 to 35 sessions or fractions, and 5 times a week for up to 7 weeks. So in radiotherapy, the developments has been trying to be more and more precise and what you call conform. So you see the 2D radiotherapy was many years ago. I trained in 2D. Then we went into 3D where you can see a tumor, and then you have the spinal cord, and the red color is the high dose radiation, and the other colors are probably the blue color is 50 grays, 50% of dose. So you can see over the years from 2D to 3D to IMRT, which is the current standard of care, is called intensity modulated radiotherapy, where we are trying to be using many beams, trying to focus radiotherapy towards the tumor and try to reduce the dose to the critical structures. And the current development is called VMAT, which is an arc therapy, where you're using multiple beam to target the tumor more precisely. So in imaging radiotherapy, what are the recent advances? We are using more MRI scan, PET CT scan, or SPECT, and we register it with the planning CT scan to accurately outline the tumor so that we can be more precise. And then we're using biological-based planning, like PET CT for radiotherapy planning. We are increasingly using artificial intelligence, both in contouring and radiotherapy plan reviews and so forth. And this is one area which has been developing more rapidly in the last few years. We're also using adaptive radiotherapy, using such as cone beam CT for checking that the position of the delivery is accurate. This is just to give an idea of PET CT. The standard on the left-hand side is standard CT scan. We use a PET CT, which is in the middle, and we fuse them together, and so that we can outline the structures more precisely. And I mentioned about checking or verifying the treatment delivery using a cone beam CT. So what we do is this is a standard linear oscillator, which I mentioned, which delivers radiotherapy through this nozzle here. And we have an X-ray machine which is attached to it, which is a flat plane detector. So before we start the radiotherapy, we check the position using X-rays, and this is called cone beam CT. What are the other developments? We're having more higher precision machines like CyberKnife, using charged particles like proton therapy or carbon nanotherapy, and we're using MRI guided radiotherapy. I'll briefly tell about them. So proton therapy uses positively charged high energy particles to treat cancer. The advantage of proton therapy is that it deposits almost all the energy within the target or the tumor, and there is very little exit dose beyond the tumor. I'll show this. So this is the machine that is, we have 2 centers in UK. One is in University College Hospital London, other is in Bristol. So just a pictorial representation of how a standard radiotherapy on the top. When you use a standard X-ray beam, it goes through the patient, deposits all the energy as it travels through, treats the tumor, and you still have some dose exiting the patient. So we are treating unnecessarily the healthy tissue beyond the tumor. While proton therapy, it deposits almost all the energy within the tumor. So there's very little dose that is escaping outside the tumor. So that way we can reduce the toxicity. Coming to MRI-guided radiation therapy, this combines a 1.5 Tesla MR scanner with a standard linear oscillator. So the advantage of using MR linear oscillator is that you can tailor the shape of the beam in real time. While in standard radiotherapy, we have a linear oscillator, we just check the position and then we deliver the radiotherapy, assuming that the patient gets a dose that we plan for. While in MR scan, we can actually check the position in real time and then we can deliver dose, particularly helpful for tumors which can move, for example, lung cancer, which, as you know, can move with treatment. And this will be helpful for lung cancers, as well as delivering higher precision radiotherapy. The other form of radiotherapy is called intraoperative radiotherapy. We have a linear oscillator in the operating theater, and you can use it to treat the tumor bed after the surgeon has removed so that we can be more accurate in targeting. You can see on the left-hand side, this is the standard IMRT where the red color is 100% dose, and we are using multiple beams to treat for this pancreatic bed. While an intraoperative radiotherapy, you can actually shield the surrounding structures and give a dose of radiotherapy to the tumor bed. And we have the only center in UK, which is in Southampton. Coming to stereotactic radiosurgery, this is using a very single high-dose targeted radiotherapy using multiple small beams. Usually single dose, sometimes up to 3 or 5 treatments. The standard treatment used to be what they call a gamma knife. On the bottom, it's using cobalt source, But currently we're using CyberKnife or linear accelerator, which is a new development. And this helps to deliver high dose for tumors which are based in the cranium or cranial tumors, including benign tumors. This is one of the areas that is seeing significant improvement because we're using more linear accelerator-based stereotactic radiosurgery. CyberKnife is a new development, which is a frameless robotic radiosurgery system that uses real-time tracking to deliver high-dose radiation. This combines a linear accelerator along with a robotic arm. So you can see in the picture, bottom picture, you have a linear accelerator which can move in different directions and can treat the patients more accurately than a standard gamma knife. Now, moving away from cranial, so we're using this precise radiotherapy to other parts of the body. This is called stereotactic ablative body radiotherapy, or SABR. And this is now increasingly being used in many cancers in NHS, and we are been implementing this in different sites. It's more useful for tumors, small tumors such as lung cancer, pancreatic cancer, kidney cancer, prostate, and spinal tumors. And here we tend to use 60 grays in 3 to 5 treatments. Instead of giving 30 or 35 treatments, we're using small number of treatments, but using more high precise beams aimed to treat the target. The recent development, which is still ongoing, is called flash radiotherapy, which is a technique involving delivery of ultra high dose radiation. So we're talking about 60, 65 grays over 30 to 35 treatments. What if you can deliver the same dose in a single treatment? Is that possible? Yes, that's possible. And there are now clinical trials, phase 2 trials now looking into see whether this would be possible to deliver. They're using currently only on animals, and hopefully University of Pennsylvania is leading these trials. And this seems to, so far the initial evidence suggests that it reduces radiation toxicity in healthy tissues without compromising the beneficial effect of radiotherapy compared to standard radiotherapy. So if this comes in work, instead of treating 30 treatments or 35 over 6 to 7 weeks, we'll be giving single treatments of radiotherapy. The next important bit is immunotherapy, which is using substance that is made by the body or in a laboratory to boost the normal immune system and help the body to target and destroy cancer cells. Now, the different forms of immunotherapy, cancer vaccines, cytokine therapies, adoptive cell transfers, immune checkpoint inhibitors, and oncolytic viral therapies. There are several clinical trials now looking into all these forms of immunotherapy, particularly is more effective, for example, immune checkpoint inhibitors in cancers like melanomas, in head and neck cancers, in bowel cancers, and in lung cancers. And these seem to improve the survival significantly. I have seen the last 25 years of being an oncologist that immunotherapy has now improved survival, particularly when patient where the cancer has escaped the primary site and spread elsewhere to the body, what we call a metastatic cancer. And these have improved survival significantly. The other exciting development is called gene therapy, which is altering the human's genetic makeup instead of using drugs and surgery. There have been different ways of using gene therapies in the past, but the new technique called genomic editing uses molecular tools to change existing DNA in the cell instead of introducing new genetic materials into the cell, which was the old techniques. And some of the exciting outcomes from gene therapies are like CAR T-cell therapy, which are showing promising results for treatment of leukemias. In head and neck cancer, which is my area of interest, we are currently having some improving or promising results, particularly using adenoviral vectors in P53. I think there are still many studies that is ongoing, which I sure hopefully will improve the way how we treat cancer patients. So far, the treatments have been trying to improve survival, but that has a knock-on effect of the quality of life for the patient because we use radiotherapy or chemotherapy. There are some side effects, significant, some of them are late side effects. And also it's important to make sure that the patients can tolerate the treatment. So I think I'm looking at the flash radiotherapy, possibly immunotherapy and gene therapy, which could be some of the exciting advances in cancer treatments, which in the near future would probably address all the three criteria which I mentioned: improve survival, improve the quality of life, and also make sure the treatment is tolerable or tolerated by the patient. I hope I've done justice in just talking briefly about the advanced cell cancer. Thank you.
Thank you very much, Ram. I know it's a huge topic, and it's just more like a whistle-stop tour for students to know about the various aspects of treatments, probably which they might not know need to know in detail. But if it comes up in the interviews, at least they can talk about gene therapy and things like that, which they are aware. Thank you very much for really spending your time and sharing your wealth of knowledge with us. Before we go on to the next speaker, I will call upon Abhishek to share a few thoughts about his views on on his coaching for the students. Abhishek joined as a student about 5 years ago, and many of you here might know him as he has done various one-to-one tutoring and helping students in their interview practice. Abhi is our MMI lead for our company, and he's going to briefly talk about his experience and what he has learned. Over to you, Abhi.
Good evening, everyone. I hope you can hear me.
Yes.
Perfect. Okay. So good evening, everyone. I'm Abhi, and I'd like to extend my gratitude to Dr. Elil Anand for the warm introduction. Thank you so much. I'd like to begin with a personal anecdote of mine. A few years ago, I found myself in the shoes of many applicants attending events like this today. I've experienced the nervousness that some of you may be feeling prior to your interviews, and I want to assure you that this is completely normal. With continuous practice, like Dr. Elil Anand mentioned before, practice is what helps lead you towards perfection. And MMI mocks organized by Dr. Elil Anand, Dr. Raji Anand, and invaluable feedback from doctors from the doctors and medical students, I gained the confidence to perform well in my interview. So upon entering my first year of medical school, I felt compelled to pay it forward. I cultivated a deep interest in education, and since then I've been fortunate enough and blessed enough to help over 50 students in securing a spot in their desired medical schools. Since the company has started Educate the World, we've been in the forefront of aiding students in various different facets of their medical application journey, spanning from medical entrance exams to crafting their personal statements, alongside with them through mentoring them, and helping them in medical interview preparation, which I'm deeply involved and passionate about. We've successfully hosted medical interview preparation events, one in person in London, which many of you may have attended, and we've done 2 online events over the last 6 weeks. We had one in November and had one in December, which many of you may have attended. And all of this has, given us extreme feedback. We've received positive feedback. As a company, we steadfastly, we believe in providing low-cost, high-quality education. And we're eagerly anticipating in bringing you more exciting events in the future, which will be inspiring and fruitful to yourselves. I'd like to conclude with a very thought-provoking quote. I cannot make my days longer, so I strive to make them better. So as a company, we aspire to provide a high quality experience for all of you. So thank you so much for everyone who's attended today, and thank you to the examiners for their wise words and thought-provoking words. And it just goes to show that in medicine, you're always learning, because even as a student today, I've learned so much from the talks we've had so far, and I'm sure I'm going to learn a lot from the talks which are about to happen. Thank you, everyone.
Okay, thank you, Abhi. We all learn every day. Even with all the senior clinicians here, we all learn something new every day. That's wonderful. We are on time and we hope to finish in the next 20-25 minutes time. We move on to our next speaker. We all know the importance of artificial intelligence and machine learning in healthcare. I'm sure it will be definitely part of your exam questions. Many of you would have been using ChatGPT and other things. Dr. Venkatesh Muthukrishnan, he's a consultant psychiatrist and chief clinical information officer. He's been a consultant for the last 12 years and is a training program director in his trust. He is interested in the use of AI in healthcare, and he's going to briefly talk about his views. Over to you, Venkatesh.
Thank you, Elil. Thank you for the opportunity. Good evening, everyone. Can everyone see the screen? And am I sharing the full screen?
Yes.
Okay, thank you. I think it's been really useful, very powerful topics up until now. And when everyone's natural intelligence might be stretched, I am here to talk about artificial intelligence. Just a quick lesson introduction. So I'm just going to talk about one particular aspect of artificial intelligence in the name of predictive analytics, what its application in healthcare, share a personal example that we are trying in our mental health trust, the advantages, some of the barriers and challenges, the implications for future healthcare professionals, including doctors and physicians, and conclude at that point. So what is artificial intelligence? It's basically a mathematical process that aims to predict future events or outcomes based on past behavior or data, and analyze data to find out patterns that is likely to help in predicting what happens in future. And this is not particularly new. The picture on the left shows. I will leave that as a quiz question for all the aspiring students to find out what it is, but it is an example of how data has been useful in all the years gone by. So how does artificial intelligence work? Again, this is a very simple framework. So we have a current and historical data. So that's considered as a test data. And data scientists build models and a predictive algorithm from the data. And then the algorithm that we developed so far will then be used on another set of data called the training data in order to assess the accuracy of the predictive algorithm. It's a very simplistic way of describing a very complex work. So I'll just talk a little bit about an example that we are currently trying in our mental health trust. So we are using a large sets of data that we have because we are a large mental health trust to try and come up with an algorithm that will predict older adults who might be at risk of admission to mental health inpatient units. Now, you heard in a talk earlier as to how it is important for NHS to continue to be effective, to be proactive, and to continue to be a preventative service rather than a reactive or treatment-based service. And it is very important to try and look after people in their own homes, as you heard how secondary care and tertiary care is probably the most expensive. And that is very true when it comes to the situation with mental health, where inpatient units and beds are at extreme scarcity. So what we do is we use all large amounts of data that we have over the years on people being admitted into inpatient units, and we are trying to develop an algorithm that will help primary contact mental health workers in terms of screening and identifying those older adults who might be at risk of admission, and therefore we can give proactive care so as to prevent at least a portion of those admissions. And it will be immensely helpful to the patients and their families because we can care for them in their own units, in their own homes, and as well as saving huge amounts of finances for the NHS. So what are the advantages with artificial intelligence? Healthcare, particularly in NHS, has got an enormous data set, and that is a huge advantage, particularly for us in the UK and in the NHS. And going forward, the future of healthcare is going to be predominantly long-term conditions. In fact, the NHS long-term plan talks about this. Just to illustrate the importance of long-term conditions, a study by the American Center for Disease Control in 2014, and that's already 9 years ago, showed that even at that point, 84% of all healthcare spending was spent on 50% of the population who had one or more chronic long-term medical conditions. So it's no surprise that it is now being considered the world's most valuable resource is no longer oil, but data. And we in NHS have a particular advantage because of the data we have accumulated over the years. But it is not without its barriers and challenges, and I'm going to talk briefly about some of them. So what is black box? So it's basically the algorithm being unable to explain the rationale to the clinician. So imagine you are a patient sitting in front with the clinician who uses an artificial intelligence based algorithm. The algorithm says X or Y, and the clinician is there just communicating that decision. If you were to talk to the clinician about rationale, then clinician might struggle, and that is a huge difficulty, and it has got significant legal implications. What if the decision were to be proven wrong? Who do you take task to? Is it the clinician or the algorithm? Thankfully, we are already doing a lot of work on explainable artificial intelligence, but it remains an issue to be sorted. The problem with data is it is dependent on the quality of data that we currently have. And unfortunately, the data that currently we have hides a lot of inequalities. And you've heard from Dr. Karunanithy the importance of healthcare inequalities. And if we are not careful, then the data might exacerbate those inequalities, and artificial intelligence might therefore inadvertently contribute to worsening of healthcare inequalities. Again, if we take care to avoid this, then it is possible that artificial intelligence can be helpful than harmful. So it also leaves us as healthcare professionals, as future healthcare professionals, the possibility that we might be looking more at data and less at our own skills, both in communication, history taking, and physical examination, and therefore increasing reliance on guidance and decision making. So the need on how to continue to train future generations of healthcare professionals in this new world is an important challenge not to be overlooked. So where does this leave future healthcare professionals particularly? I think it is important. It is no longer a desirable criteria that healthcare professionals develop digital and data competencies. Going forward, it will become an essential criteria. It won't be long before patients start asking us, we know about your clinical competencies, but what about your digital and data competencies? Healthcare informatics will become more of an essential skill, and our ability as clinicians to make sense of the huge amount of data in front of us and to use that effectively and proactively for patient care is going to be such an essential skill. And it's not just a technology platform, but healthcare professionals, particularly medics and physicians, need to engage with patients and carers in a user-centered design work, because without a people and process, technology on its own is no use. So just to summarize, artificial intelligence is about leveraging the enormous data that we currently have in the UK and NHS. And long-term conditions is the present and future of healthcare, which means we will continue to generate data at a humongous rate. And we need to then be able to leverage the data, make sense of that data, without which all the data collection will become pointless. And there are lots of issues to overcome, and that can be done only through clinicians having appropriate digital competencies and engaging in partnership working with patients and all the artificial intelligence platform. The world is going to be very different, very exciting, and hopefully positive and optimistic. And these are some of the books that I would highly recommend. The books on the left, The Deep Medicine and The Digital Doctor, has led to a complete revolutionization of NHS structures, particularly in the form of creating new digital roles. I am occupying one such role called the Chief Clinical Information Officer. All NHS trusts are expected to have that role, and a raft of digital clinicians supporting the role of the CCIO. The book, A Hello World, is a very good book in terms of demonstrating the value of technology, particularly AI technologies, and how they sit alongside human beings. There is a lot of scare about artificial intelligence replacing physicians, particularly, which this book argues will certainly not happen. Artificial intelligence will be an absolutely useful tool, an adjunct that will improve the effectiveness of the clinicians. But without human beings, technology on its own is very unlikely to be helpful. And the last book is Gary Kasparov's book on his experiences of fighting with the artificial intelligence-based machine, and he lost his match to the artificial intelligence machine. And thank you and best wishes. Thank you.
Okay, thank you very much, Venkatesh. For students, it's a very important topic, and definitely it will come out in your interviews. And thanks to Venkatesh for reassuring us that we won't lose our jobs, and robots won't take over human beings. Thank you. We have the final speaker today. Dr. Raji Anand is a GP partner and a GP trainer with special interest in ophthalmology. She performs minor surgery in a busy practice in Yorkshire. She's very keen on promoting self-care and takes active part in Curry Watchers, which is a self-care motivated fitness group. Yes, you heard it right. It's called Curry Watchers. Okay, over to you, Raji, to talk about the challenges in the GP practice and primary care, which is again an important aspect for students to know.
Hi, everybody. It's been a very thought-provoking evening so far, and you've heard a lot from all my secondary care colleagues about the challenges that are facing us, the positive spin on artificial intelligence and how it is going to stay, including cancer treatments, as well as NHS challenges, and what is the enormity of public health initiatives that we need to be incorporating. So my topic today is what is happening with GP crisis, GP NHS shortage. So I briefly want to kind of touch base on what is the role of a general practitioner, because for you guys who are all in your A-levels, it is quite important to understand the structure of NHS, and it's divided into primary, secondary, and tertiary care. And the role of a GP. GPs are primary care physicians, and everyone in UK should be registered with a GP practice. And GPs are responsible for the overall health of the population within their catchment area. So GPs manage, treat, prescribe both acute presentations and chronic conditions. You heard about the plethora of conditions that are impacting the NHS, and acute presentations could be starting from a cold, cough, to a chest infection, and other presentations like chest pain, to chronic conditions like diabetes mellitus, hypertension. And they also not only deal with the physical health problems, but they also help to diagnose and treat mental health conditions. So the way they go about doing it is they arrange for investigations, they refer patients to secondary care, they follow up patients and provide continuity of care. And you also heard about the public health initiatives, and health promotion is a very important role and responsibility of general practitioner. So what is happening to general practice, and why is there a crisis at the moment? So general practice is considered to be the cornerstone of the NHS. And if general practice fails, then it is considered that NHS will fail. You're hearing about the junior doctor crisis and junior doctor strikes, and consultants are striking. And so far, you've not seen GPs striking, because if GPs start striking, if NHS will certainly fail. So, however, despite all this, currently NHS, and particularly in GPs, are under a lot of scrutiny and a lot of negative publicity. And to kind of give you a shed spotlight, what is the scale of the problem at the moment? Last year alone, NHS lost about 646 GPs in England, meaning that there is now a shortage of overall 4,000 GPs all over UK. 1 in 7 GP posts are currently vacant, and this is the NHS GP data. And following current trends, in a decade's time, 1 in 4 posts is likely to be vacant. According to Health Watch, which is a patient body, 50% of patients complain not about the quality of care, but not being able to book an appointment with a GP, And 70% of people in the UK are confident in their ability, are not confident in their ability to get a GP appointment when they need one. So you can see the sheer scale of the problem that we are facing on a day-to-day basis. And this problem is only increasing, ever increasing at the moment. And why is this shortage? What is happening at the moment? As Dr. Raghuram correctly said, it is a tremendous mismatch between the demand and the capacity that is available. Simply put, more doctors are leaving general practice than entering it. Older GPs are retiring at a faster rate than we are able to produce younger doctors for entering the specialty. And as a GP trainer in a very in a voluntary vocational training scheme, we see that our posts are constantly vacant and we are struggling to recruit. And there's another problem that GPs are facing. Our GPs are not paid as much as hospital consultants. The secondary care colleagues would say partners are earning more, but partners are few and far in between. So increasing demand of workload. And you can see that the role of the general practitioner, as you can see, the roles and responsibilities are tremendous, but it is meant to be kind of met within a 10-minute consultation per patient. And this is causing a tremendous amount of negative downward spiral. GPs are constantly leaving their profession, and thereby the remaining GPs are left with a higher workload. Since 2015, the number of patients looked after by an average GP has increased by 15 to 16%. And this makes more GPs to kind of leave, stress and burnout, and because of lack of work-life balance, professional dissatisfaction. I can keep going on and on about it. So consequences of this shortage has led to not only a negative portrayal of GPs, and thereby at 8 o'clock, there is a scramble to get the appointments, and patients cannot access timely and appropriate care for their health concerns. This leads to delayed diagnosis of severe conditions such as cancer, and late detection then leads to an adverse impact on an individual's health prognosis and treatment. We heard about Dr. Karunanidhi's health inequality, and we are ever increasingly seeing patients in the most deprived areas report least positive experiences. And switching to remote consultations has disadvantaged elderly and the vulnerable patients. And because of the lack of appointments, we see a spillover to A&E, and thereby secondary care as well is put under pressure. So this is a constant kind of downward spiral that we are seeing in NHS at the moment. So what are the potential solutions? And as Dr. Raghuram aptly said, it is increasing funding. We need to increase the funding towards the pay, towards the doctors. You can see with the junior doctors striking, it is this lack of pay and the incentive that is clearly having a negative impact on the profession as such. And we need to train and recruit more GPs. The GP NHS force plan is at the moment to increase 50% of the training places to 6,000 by 2031. And GP trainees need to be spending more time in general practice as such, because at this point in time, vocational training program courses is such that they spend 2 years in hospitals and just 1 year in general practice. And Royal College of General Practice is advocating that their time spent in general practice needs to be increased. And we are also looking to see if we can increase the role of other healthcare practitioners. Say, for example, there is kind of looking into ANPs, helping and supporting GPs in their day-to-day primary care work. Paramedics have been recruited into helping primary care physicians, but there is already shortage of ANPs and paramedics, and hence the work-life kind of balance is still not being improved by incorporating more of these healthcare professionals. And promoting health education and thereby self-care among public. One of the reasons being that, again, it comes to demand and supply. If every cough and cold kind of pitches in with a GP, the GPs are not able to give appointments for the really unwell patients, and thereby the appointments are getting taken up by unnecessary kind of health conditions, wherein if we can create self-care awareness among public, and as you rightly pointed out, that NHS public initiatives are long-term conditions are here to stay, and long-term conditions like diabetes and hypertension can very well be dealt with. It becomes a social disease almost. If we can tackle obesity, we can tackle smoking, there is a lot that we can be able to provide our patients. So GP shortage is also by helping promoting health education. So top tips for answering any of these questions. So you've heard about a lot of our speakers, and the scenarios here, the hot topics are all complex and challenging. And how do we kind of look at it? You can kind of talk about it both from a doctor's perspective of how it is kind of impacting the NHS, but also it is very important. Patients are the heart of NHS. So it needs to have a patient-centered approach. And as Dr. Karnanidhi rightly said, it is about talking about health inequalities. Health inequalities are currently exponentially increasing, and thereby it is quite important to address these health inequalities if we can have positive outcomes. And AI and so on can possibly help with us to kind of look into all these areas about how to tackle these kind of problems and link it to help your work experience, because every answer that you give in these kind of scenarios, if you have had kind of attended these kind of talks, if you have been to kind of any primary or secondary care, link it with your work experience, because the more you are linking it with your work experience, the personal knowledge that you have gained by work experience will stand good stead in answering these questions. And I just wanted to kind of share some possible questions associated with the general practice related about what is the role of a GP? You might be asked, how do we address lack of GPs in UK right now? How do patients perceive about their own GP practices? What do GPs do in their daily basis? So it's quite important to be aware what is the roles and responsibilities of GP. How is public impacted by GP shortage? How can we fix? What are the solutions that can possibly be available? Thereby we can cut short. There is quite a controversial suggestion of Rishi Sunak suggesting that £10 charge from every missed appointment. So what do you think of it? You should have a kind of a balanced view on it. It's quite a controversial topic, but some of the universities might bring it up to see how you stand on it. Who is most affected by GP shortage? Again, health inequalities, as Dr. Karnanidhi was suggesting. And what do you understand by health inequalities? What is postcode lottery and how does it apply to general practice? Aside from GP, who else may work in a GP practice? So it's quite important to be aware of what is all the multidisciplinary teams that are available and who practice along with general practitioners within a GP surgery. And what does it mean to be a GP partner? And what are all the pros and cons of this? So these are just a few example questions of how this topic might come up to you guys while you're having your MMI interviews. And one of the most important kind of quotes of Chris Lewis says, you can't go back and change the beginning, but you can start where you are and change the ending. And this was quoted recently in BJGP, trying to address the challenges that are facing NHS at the moment. So good luck for all your upcoming MMIs, and go on rock. Best wishes to all of you.
Thank you very much, Raji. Thanks for talking about the challenges and all the solutions, which I'm sure will be helpful for the students. I'm mindful of the time. We are running 5 minutes late. Can I ask all speakers to come on screen? And probably, most of you have answered the questions in the chat box, but probably just a couple of them, and then we'll be finished soon. First question to Dr. Raghuraman. Can you just briefly say in a minute, how to reduce burnout? The burnout it's been talked about in the NHS, and if there is a question on burnout, how do you manage?
First thing is about recognizing burnout. Can you hear me?
Yes.
So firstly, recognizing burnout is a key thing. So looking at how you reflect, what are the stress relieving techniques that we use, we advise that get your help early once you recognize this. And there are a lot of evidence in literature suggesting what could potentially be a burnout in this. So when you identify this, seek help and use any technique that works for you. And I would suggest self-care, sort of self-mindfulness, meditation, exercise. All of it is part of your self-care, which will help you deal with your burnout. What are the triggers that make your burnout? Mostly overworking, I guess. I think escalating that at an early stage rather than when it is really causing a harm in your life. I think these are things that I think the organization is in a current situation to help view and also resolve this. So again, escalating this when you've got problems. Trainees are already given this exception reporting. There are mechanisms for trainees to report their overworking burdens, and that is taken very seriously. If it is not taken seriously, you have other opportunities such as freedom to speak up. You can express your dissatisfaction or your concern to any other means anonymously and help get this help you need.
Okay,
These are
thanks,
small
Raghu.
things. Again, this is a very broad answer, but if there are any genuine concerns, anything, please do get in touch with us. We'll guide you to the right place.
Okay, thanks, Raghu. Next question to Dr. Shakti Karunanidhi. What works better to influence public health? Will there be a punitive or punishments like sugar tax, bans, or is it public education? Can you keep it briefly in
Yeah,
under 2
great
minutes,
question.
please?
I mean, roughly speaking, about 20 to 30% of our health outcomes are determined by NHS, and the others influenced by political, social, environmental, economic determinants. So my response would be there needs to be an appropriate balance of both regulation and regulatory restrictions, as well as education and service provision. So these three work as a corners of triangle. But what we're seeing increasingly is commercial interests like advertisement and marketing of health damaging products are becoming a pattern. And I think as healthcare workers, we need to be more aware of it and develop our advocacy skills to influence policy.
Okay, thank you, Shakti. I request everyone to remain on screen while Priya just thanks everyone and then we'll end the meeting. Over to you, Priya.
Thank you, Dr. Anand. Bear me just one moment. Okay. Hi everyone, so my name is Priya. I'm the Operations Manager for Educate the World. I want to thank you all for attending today's event, and I especially want to thank all of our senior doctors, Dr. Rohit Shankar, Dr. Raghuraman, Dr. Shakti Karunanidhi, Dr. Ramkumar, Abhishek, Dr. Venkatesh, Dr. Raji Anand, for taking the time out of their schedule in speaking in today's event. I hope you found today's session informative and insightful. And I'm also going to talk a little bit about our company and future events that we will be hosting. So Educate the World has been running for the last 6 years by Dr. Ilal Anand. The motto of our company has always been low cost and high quality education, and we still hold by that motto today. I joined the company in 2020, and I've seen how much of an impact this company has made for students wanting to study medicine. We have been doing many events, from seminars on the process of going to medical school to MMI mock interviews, which are also on our YouTube channel. And they've all been a great success. We've had students come to our events as candidates, and they've come back as examiners. And we have people who will be graduating this year as well. We are also planning UK MLA training for UK and international graduates. We're also starting our dentistry and veterinary training sessions next year, in addition to soft skills training like leadership, assertiveness, self-confidence, and management skills. If anyone wants one-to-one tutoring for medical students, please get in contact with me and we can arrange that. And our next paid group session is on January 7th, and we'll be posting the booking details later tonight. Thank you.
Okay, thanks everyone. Enjoy the rest of the evening. Thank you. Bye-bye.